are bradycardias or bradyarrhythmias. So bradyarrhythmias are the worst ones, so we'll start with those ones first. They're usually because they're going to make, the reason why you have a bradycardia is because it's something that's going to make you die. So you can think of D for drugs. Drugs caused it. I, ischemia. Which vessel can cause bradycardias? That's the RCA, right? And then electrolytes that are too high usually cause a bradycardia. One we're thinking of usually is hyperkalemia, right? You're hyperkalemic, things start shutting down, things can't work, concentration gradients are destroyed, and you can no longer conduct electrical signals to the body, right? Especially the heart. So, and also the muscles. So the muscles of the vasculature relax, and you start getting low blood pressure, and you start getting low heart rates. And then low blood pressure leads to the lack of flow to the kidneys, and the kidneys do what? Get rid of potassium. So these three things, that's really a key that your patient is about to code. When their heart rate's low, hyperkalemic, and they're not, and the blood pressure's low, that's a problem, right? So that's something to think about when you have bradycardia. Worst case scenario, or are they hyperkalemic and you realize, oh, they have end-stage renal disease. Oh, the K was drawn yesterday morning and it was 6.5. That's a problem, right? It's like, did we give treatment? So you got to look back and see if they gave the cocktail or not, right? So we want to make sure we're looking for electrolyte changes. Are they hyperkalemic, hypercalcemic, magnesiemic, and acidosis? As we know with a high K, you also get high pH, or sorry, high pH, you get high acid levels, which lowers your pH, right? And then the same by the flip side. You're really, really acidotic, you're going to start getting really, really hyperkalemic. Okay, so checking recent chemistries, and also checking to see if they're acidotic. And how do you check to see if someone's acidotic? Is there a litmus test in the break room? How do you know? You do the venous CO2 trends, right? So on your chemistry, you can see your bicarb went from 21 to 17 to 11. That's telling you that that's a substitute for your bicarb. But getting ABG is important. As we mentioned, you want an ABG when your patient is hypotensive. You want to figure out what is causing this. Is it someone that's acidotic, or is it someone that is, you know, why is this happening? Is their blood pressure low right now? Okay, and of course we investigate, is it ketones or is it lactate or is it, you know, lack of blood flow, what's going on. But electrolytes are one of your key things that can cause you to be bradycardic. And again, when you have low cardiac output, low flow throughout your body, because whether it be a like cardiogenic shock or a shock process or even hyperkalemia and acidosis, all these things are going to lead to a poor cardiac output. But bradycardia itself leads to poor cardiac output, right? Your cardiac output is your heart rate times your stroke volume. What we say stroke volume was about 70 to 100 cc's. Let's just say 100, and a heart rate of, let's say, 50, right? That's 5 liters of output. 5 is normal, right? 5 liters per minute is a normal output. But when it starts getting a heart rate of 45, 40, that's a less and less cardiac output, right? And who gets concerned? The gut gets concerned. It starts getting nausea, vomiting. My liver gets concerned. You're going to see transaminitis, a rise in the AST and ALT. And then I'm going to get weak and fatigued. My kidneys are going to start having reduced output if I'm tracking that. My heart is going to start not getting flow, right? So it's going to start getting what? It doesn't get the flow it needs. That's going to be chest pain, right? And my brain is going to start getting confusion. My skin's going to start getting cool and clammy. And because my SNS is probably going to fire off to try to correct this, but sometimes the SNS can't work because they took beta blockers, right? They took drugs such as beta blockers. They can't get that response mounted, right? Or they're severely hyperkalemic. The SNS is going to go down and try to tell the heart to go faster, but they're too hyperkalemic to do it. So all this poor cardiac output leads to lack of flow to all the organs, and yeah, lactate could go up, but the patient's going to complain of what? Chest pain, shortness of breath, hypotension, confusion. Any one of these 4 things, it clues you in that you have a patient that's sick, right? And it has a poor cardiac output, I should say. So they say, oh, I got some chest pain. Let me check your blood pressure. Oh, shoot, blood pressure is 84 systolic. It's like, are you feeling, and they're a little confused and a little wild. They're like moving around. You put restraints on them earlier. These are all signs of poor cardiac output, right? You've gone up from 2 liters to 6 liters of nasal cannula. These are all signs that they're getting low flow to their organs, right? And it could be due to bradycardia. Anything that drops cardiac output will cause these symptoms, right? These are universal symptoms for low cardiac output, right? So they have poor flow to their organs. And why that's happened? Because of the bradycardia. Again, bradycardia is part of cardiac output, right? It's only like 20% of it. It's not really a huge portion. The biggest portion is stroke volume, because you can adjust stroke volume by increasing inotropy, you can increase your fluids, you can do all kinds of things to fix stroke volume. But once the heart rate's 40, you can't regulate that, right? You can't change it around. Your body might try, like with the SNS, but that's why we have some of these situations that might interrupt that normal fix to our heart rate. So again, D for drugs, right? So we might have taken too many beta blockers. There was someone on amiodarone drip, and they got all these long pauses, like our friend over there had a huge 6-second pauses. Their heart rate's in the 40s. They don't need amiodarone anymore, right? And then digoxin, you can get dig toxic if someone's on it already, or they were getting it. Calcium channel blockers specifically are ones that only affect the heart rate, right? Are diltiazem and verapamil. And then ischemia, as we mentioned, they are, you're trying to send the SNS signal down to make the SA node fire off faster, but the SA node is dying. It's like, I can't do it, friend, right? Because it's a lack of flow to the SA node because the RCA is occluded, right? And then severe hypoxia. That's with a hypoxia to the heart, but also hypoxia to the brain, right? Hypoxia to the brain, the SNS signal came from the brain, it came from the medulla. And if we don't have the flow to the medulla, you don't have the glucose to the medulla, you don't have the oxygen to the medulla, then all those things are going to lead to a lack of SNS output, right? And electrolytes we mentioned as well. And then something else that comes from the brain that makes you cold or hot, or will make you cold if you don't have it released from your brain is what? What hormone is that? You start getting super cold if you don't have this hormone around. Thyroid, right? T3, T4. So if someone's hypothyroid, they're going to not be they're going to be super cold. And also the thyroid hormone is what upregulates your SNS system and that makes it work. So obviously you'll get bradycardia if you can't upregulate your SNS. You can't use your SNS. So hypothyroid patients are at risk for bradycardias, and they are cold to the touch. So whenever your patient's like really, really cold, you come in and they're like on a warming blanket, it's like, well, shoot, why are they cold? They shouldn't just say, oh, I guess they're just cold today, right? It's like, I guess they got the AC, it's called engineering, right? It's there's something going on. Are they hypothyroid, or what's happening? Okay, and then are they sleeping, right? So sometimes someone's sleeping and the heart rate's like 44, and you got every nurse like running around, it's like, oh, they're 44, they're 44. I set my alarm to 43, they're 44 now, right? That's fine, right? So the magic number to the life, universe, and everything is 42, right? So that's also literature. It's not just because I like Douglas Adams. So if it's 42 is actually the number they decided is. If it's less than 42, you get a little concerned. If it's 42 or higher, you're just we'll continue to monitor, right? So that's all we're going to do is watch the heart rate after that point. As long as we look at the other things. They're not on beta blockers, they're not ischemic, and they're not hypoxic and such, right? And then what else? Less than 42 is concerning. But what if they have like a massive stroke? Well, that medulla doesn't get blood flow because of the stroke. That can cause a bradycardia situation, right? They're altered, they get no medulla equals no SNS, right? And then there's some other weird causes, like for instance, post-cardiac surgery or like a ruptured peptic ulcer, and it starts tickling the vagus nerve. And what does the vagus nerve do? It's the opposite of the SNS, right? So it's going to lower the heart rate, right? So if you tickle it, you're going to stimulate it, and you're going to make it lower the heart rate. And that can happen with like surgical situations, or like they have a perforated ulcer that's irritating it. All right, so the big four get hyperkalemia, they got ischemia. There's the Brady bunch here, right? Our Brady bunch is our beta blockers, digoxin, non-DHP calcium blockers, amiodarone. All these things are things that can lower the heart rate that we want to try to assess, right? Over here in the corner, what's going on there? That's definitely ST elevation, right? 2, 3 AVF have ST elevation. I probably want to look at 1 AVL for reciprocal changes, right? So those are all different. That's a sign of ischemia that could be explaining my bradycardia, right? So these are things we get labs for, things we're going to assess to make sure my patient's okay, right? All right, so also when your patient is bradycardic, the first thing you're asking yourself is it symptomatic? And how do I know they're symptomatic? That means they have symptoms, right? So they have chest pain, shortness of breath, hypotension, confusion. Any one of those things means that they have, a lack of cardiac output, right? It might not be the bradycardia. It might be like a really fast tachycardia, or it might be a shock state. It might be something that's making my cardiac output poor, right? So again, the brain, heart, GI, and SNS will be trying to, will get symptoms, right? They'll start getting diaphoretic and cool because the SNS is firing off. They're going to say, I have a feeling of impending doom. They're going to tell you, I feel like I'm going to die. And if you've ever talked to an older nurse, they're always saying, you got to trust them because they might, right? They will code very soon. It's because their SNS is firing off. It's like, how come they're not diaphoretic, or how come they don't have that symptom and that symptom? They're not even tachycardic. Well, it's because probably they're diabetic and their nerves are fried, right? They don't have the ability to give you those symptoms. Okay, so heart rate, again, is a big part of this equation that tells us what that is important to providing cardiac outputs, right? So poor cardiac output can happen from significant bradycardia. Of course, there's other reasons, but that is a significant reason. Okay, so how do you fix bradycardias? Well, first of all, do you need to fix it? Is it stable? Then you're going to try to fix the underlying cause. How do we know it's unstable? They have symptoms, right? So they have symptoms. You're going to say, well, shoot, are they breathing? Are they, what's the blood pressure? I can try to resuscitate that, but we try to figure out the underlying causes of die, right? Is there drugs that we need to reverse? Is there ischemia that we need to fix? Is there electrolytes that we need to fix? Let's get us some stat labs to see if the potassium is normal, for instance, right? There are reversal agents we can give, like beta blocker overdoses or calcium blocker overdoses. You can give calcium for calcium blockers. You can give lipids and for both beta blockers and calcium blockers. You can give glucagon for both to help reverse those overdoses. If they overdose on their DIG, you can give DIG bind to bind the DIG in their body, right? If they have for instance, they have like overdose on plants, right? Yeah, so organophosphates are plants. But so there's other things we can do to figure out what's, why they're bradycardic. And usually atropine is our go-to, right? So we're going to give atropine to hopefully restart the heart and anticholinergic properties will block the vagus nerve and make our heart rate go up, right? But again, these are all the things we've been talking about. These are all different cardiac reasons, pulmonary reasons that could be causing a bradycardia of some sort. And the bradycardia can manifest in many different ways. It can be just sinus bradycardia, or it can be a huge block of some sort, right? It can be like a sinus arrest in that situation. We can have an AV block of some sort, where we have just a prolonged PR interval, or we have complexes that get dropped because the AV node is being so suppressed that it's not letting the P wave get through at all. And so we have dropped complexes, for instance. All right, so that's the idea behind bradycardia. So we're making this, is it unstable first? And then what do we do next? We got to treat the underlying cause. So to treat the underlying cause, yeah, that's important. But what if you can't, you've tried that, you're getting the therapy, and they're still bradycardic because you have a sicker patient. So again, we're not treating unless it is symptomatic. And atropine is usually our go-to agent, right? Usually atropine we're avoiding in second degree, type 2, and third degree blocks because it doesn't work and it can actually worsen a little bit. All right, and what else? So if atropine doesn't work, you gave how many doses is the max for atropine? 3, right? So 3 milligrams in 24 hours is the max for atropine. So we want to make sure that, what else can I give? I ran out of atropine options. We have SNS in a bag, right? We have a epinephrine in a bag. We have dopamine in a bag, which is a precursor to norepi and epi. And we also have isoproterenol. The OL tells you, it sounds like albuterol, right? What are OLs? OLs are beta agonists, right? Not beta blockers, but beta agonists. And you have beta receptors on your heart, so it's going to raise the heart rate, hopefully. Okay, so these are meds we can give, or infusions we can give to fix someone's bradycardia. If that's not working, we might have to do pacing, right? First, we start with transcutaneous pacing, and then we move on to transvenous pacing, right? And if that doesn't work, the medication doesn't wear off, things aren't resolving, we might need to do a permanent pacemaker, right? They might just be bradycardic because they're old, right? Their SA node has died, right? So before they have. So it's a way they might just need a permanent pacemaker at this point. But if we're doing transcutaneous pacing, you use our Zoll machine, right, our defibrillator. You just churn the knob over to the green section there. So the green section says pacer. And that's what you're going to turn it to pace, right? It has 2 different values you're worried about. You're worried about the MAs and the rate. So the rate you want is probably not going to be 40. It's probably going to be like 60, 70 even. So you want a normal rate at least. Don't be a cowboy and do like 120. It's like, you got this, grandma, right? So you want to make sure it's a normal heart rate. And then the MAs you just crank up until you get what? is capture, right? So capture is key, right? Once you see the capture, once you see, first you start seeing the complexes go on the screen, see little pacer spikes happen, and once you see capture, you go about 20 points above that, right? You're going to, raise the MA just a little bit more, just so we get capture throughout the night or throughout the day, okay? So you may need a transvenous pacer because this is temporary. It's called transcutaneous pacing, and yes, technically transvenous pacing is temporary, but you can only do transcutaneous pacing for about 2 hours on these Zoll pads. They're going to dry up and they're not going to be effective after that point. So after that point, you got to switch them over so they don't dry up to these pacer pads, right? These are the what are they called? Pro pads, right? That's for the Zoll monitor. So you got to switch them over after 2 hours if they're going to continue on transcutaneous pacing. They can't get to the cath lab, for instance, for transvenous pacing. And when you have someone on transcutaneous pacing, what are they going to do? Ow, 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 ow. At whatever rate you set here, it's going to be ow, ow. It's at 70, ow, 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 ow. So it's gonna hurt, right? Yeah, or other expletives, right? So yeah, so you want to make sure that's, do we really, you want to test it sometimes. You want to hit the little 4 to 1 button down here. See the little 4 to 1 button? You press that to see the underlying rhythm, because maybe they're out of it, right? Maybe their underlying rhythm is 60 and it's sinus, right? You don't have to keep them there on that machine all night, right? So you look at the underlying rhythm, or you press it, it's like, oh shoot, they look like they're asystole. I'm going to let go of that button, right? So you do want to assess this every 4 hours at least. You want to assess what is going on underneath this pacing event, right? And then transvenous pacers. Patient will not say ow when you have a transvenous pacer. It can be placed at the bedside. I've maybe seen it once placed at the bedside, but it's usually placed in the cath lab under fluoroscopy. So they know it's going right into the right ventricle and it's going to pace it, reliably. Because if they place it at the bedside, it could be in the right atrium. You want it right seated in the right ventricle. Okay. And again, that transvenous pacer can be in for like 2 days, 3 days, but if it's not clearing up, the bradycardia is not resolving, they may need a permanent pacemaker to get this resolved. And anytime you're on a transvenous pacer or transcutaneous pacer or a pacer, permanent pacemaker, you need to be assessing what it is doing. Is it getting capture or is it not? Is it pacing appropriately or is it not, right? So those are called failure to pace, failure to capture, and failure to sense, all right? So these different things we're looking at to make sure our pacemaker is working properly. Failure to capture makes sense, right? What do you do with a pacemaker? You capture someone's heart, right? So you have to capture the heart and make it, beat when the pacer is beating, right? And the pacer spike's going off, you should see usually a QRS, a big, nice, weird, wide QRS after that pacer spike. If you don't, see right here, we got little signals right there, little pacer spike, but where's the capture at, right? Did not capture, right? And then failure to pace means there's no pacer spikes. There they are, and where'd they go? That's failure to pace, failure to pacemaker. It's failure of the machine. The machine's not working. Someone did not change the battery on your transvenous pacer, or you did not plug in your Zoll, right? So you want to, you can go through all the effort. You got them back. You coded them. You got them back, and then the Zoll is not plugged in. And what should the Zoll be plugged into? A red outlet, not just the wall. Don't make holes yourself, right? Engineering frowns upon that. All right, so yeah, you want to make sure that it's plugged in. So your transcutaneous pacer is working. Make sure it's plugged in. Otherwise, it goes off on you and you're on lunch. It's like, oh shoot, now the underlying rhythm is asystole. Or you find out there's sinus rhythms. Oh, you don't need this the whole time. Look at you, right? So yes, we want to make sure that we have a working pacemaker. And if it doesn't work, that's failure to pace. And then failure to sense is a little bit tricky. That means that we are pacing. You won't see this with transcutaneous pacers, but you will see with transvenous and permanent pacemakers, where there's a setting off where we're not, you're not seeing the pacer spikes are there, but they're like haphazard. They're not detecting what's going on, or they're detecting extra stuff going on, like the patient moving. It'll say, oh, that's a QRS, boom. All right, and it'll start to pace them on odd points in the cardiac cycle. So you'll see you got a pacer spike there before the QRS, you got a pacer spike right there on the T wave. Uh-oh, what does that mean? It's a risk for R on T phenomenon, or torsades can easily happen when that happens. All right, there's a quick algorithm so you can work through it to see if you have a patient that is operating properly on the pacemaker. All right, so transvenous pacers, they have little battery compartments behind them, right? You've got to replace the battery, otherwise it's not going to work, all right? It doesn't plug into the wall. Transvenous pacers are, they are temporary, and they are battery powered. The battery will last about 20 hours or so. So usually every 24, or I should say 20, they last more than 24 hours. So you definitely want to change it on your shift, right? You want to ask, when was this changed, right? So on these ones, we have rate and output. We're used to seeing those, right? The MA and the millivolts. That's the same thing as a transcutaneous pacer, but now we're going to add a little more complex one called sensitivity, right? So sensitivity is weird because everything on here you want to be able to crank up to 11 if you don't get your patient working, right? Your patient's still bradycardic in a big stressful situation, like dial it up, dial it up, dial it up, and that should hopefully fix the patient. But sensitivity, if you look at the numbers on the device, they actually go backwards, right? Because sensitivity is, you're going to think of it as like a gate or a fence, right? If I turn the sensitivity down, right, that makes me more sensitive, right? It makes me more sensitive to the heart, right? So that it sees the complexes and it will fire off. If it's too sensitive, it sees the T wave spike, it sees the QRS spike, it sees a little artifact, the moving spike. That's too sensitive, right? But then also we can raise the fence. That's what you're dialing this way. And that's going to raise the number. Remember I told you numbers are backwards? So that will make it less sensitive, right? So you're like, your boyfriend's less sensitive now, right? He doesn't understand me. He doesn't listen to my heart, right? To my P waves, right? So that is oh, I saw some looks, all right? So yeah, that sensitivity is something that can be adjusted. It's another setting that is used on the transvenous pacemakers, okay? So transvenous pacing is inserted via a sheath, right, into the patient. This is there's the patient right here, all right, coming, and it's inserted just like our femoral sheaths, and then through that sheath comes a pacer wire, or a transvenous pacemaker, which will sit inside the right ventricle and pace the patient, right? So things to keep track of, we want to make sure we have a TKO line going there, right? So TKO needs to be infusing, otherwise your pacemaker is going to it's going to clot off, right? So we want to make sure we have good flow through it. You probably want some heparinization through it as well, so that that sheath is not going to clot off on us, right? You can pace the atria too, but usually we're just doing ventricular pacing. Okay, change the batteries at least every 24 hours. We can't trust these. Some of the newer ones I think have a little battery marker, right? It's like they've upgraded since the 90s. Like I've seen, like my Game Boy in the 90s had little battery markers. I'm not sure why a $20,000 machine doesn't, but either way, you want to make sure that you're changing the batteries at least every 24 hours. And then sometimes other pacemakers you might see with this box here would be with epicardial pacing, which is used for CABG patients. We talk about that more when we talk about CABGs. But it's the same deal. You're assessing the sensitivity, millivolts, milliamps, and you're assessing if it's working or not. That's our job, is to make sure it's working. You can assess the underlying rhythm every 4 hours. And of course, if it's transvenous, you're changing the battery. And if it's transcutaneous, you are trying to get a transvenous pacer if it's been a while, but also you're making sure your Zola defibrillator is plugged into the wall.